everyone. Can you guys hear me okay before I start talking for extended periods of time?
Yes.
Okay, perfect. Thank you, whoever said that. So my name is Emma. I see some familiar faces or names out there rather. So welcome. If this is your first time here, welcome regardless. We're happy to have you. I'm excited to be giving this talk about anemia. I like the subject of anemia specifically, and I love giving these talks about virtual rounds. And we certainly appreciate your guys' attendance and your guys' participation. So without further ado, let's go on to our next slide here. All right, so in terms of updates, this was newly updated as of a couple sessions ago. Becca had put the link in the chat, and if you haven't, she can drop it in there again. That has the SOAP note, it has the quiz, and it has a few questions for feedback. So you guys can give us a little feedback at the end of the session. That would be great. The quiz is 10 questions. I created the quiz for the session, so it shouldn't be too painstaking to complete it. If you sort of pay attention to the talk today, you should be able to hopefully get 80% in the first try. So don't get too stressed out about it. It should be fairly simple. Other than that, we do have a Google folder. It has info and updates. We do have the link in the chat as well for that. Okay, so as promised, last time I gave you guys a read. Did anybody start reading that book, or at least Google it or look into it? While you guys type out your answers for that or unmute yourself, I do have another one for you. This is by Jerome Groopman. He is an oncologist, and he wrote this book and a few other books. This one is called The Anatomy of Hope, and it really just discusses basically the way people kind of prevail in the face of illness. So I recommend this one if you guys need a book to read. I know some of you guys are busy preparing for the upcoming application cycle, but if you have any time, need any downtime, this is a good book to take a look at. Oh. So here's your guys' joke for today. Anemia is our topic, but you can't talk about anemia without at least throwing in the white blood cell. So with that, I do have a question for you guys. Like the last time I presented to you, I do have a pre-poll question. So let me launch that for you. So take a few seconds. I'll give you about 30 to 45 seconds or until everybody has answered. All right. So I'll share that with you guys. Hopefully you can see that. So a little bit all over the place. Nobody says that they know a lot. You guys are probably very humble. I bet some of you guys do know quite a bit about anemia. And most of you, the vast majority of you said that you know a little bit. So hopefully we can kind of enhance that knowledge today. So let me close this poll. All right, so same kind of outline as last time. What we're going to do is we're going to go through a case. We're going to talk about the physical. We're going to go through a physical exam. We're going to go through a differential diagnosis, and we're really going to emphasize the assessment and plan, as well as talk about the pathology of the disease. Because anemia can be a complex topic, I hope to kind of shift the emphasis to talk a lot at the end about anemia. So. And if you guys have any questions along the way, feel free to ask those. I'm happy to answer any questions that you guys have. There's no dumb questions, truly. And then as always, I would love for you guys to participate throw your answers, unmute yourself, whatever you guys are most comfortable with. Just be active in the presentation. I think that is certainly a way that you guys can enhance your learning as well. So, and here's the SOAP note format. As kind of a review, if this is your first session, the subjective is really going to be what the patient tells us. So if they tell us that they have a fever, we're going to put fevers in the HPI or in the ROS. If we measure a fever, we're going to put that in our vital signs under objective. In addition to that, we're going to document our physical exam findings in objective as well. And then the A and the P of the SOAP is for assessment. So that's what we think the patient has, along with our differential diagnosis. And then we're also going to emphasize the plan. So what we're going to do based on those differential diagnoses. And if you guys have any questions at all about the SOAP note, let us know. There is a medical terminology sort of dictionary in the resources folder. It kind of lays out some of the terms that you guys may be questioning. I'll try to kind of be a little clearer in terms of the medical acronyms so that you guys can sort of keep up with that as well. Started with the case here. Today we have a 53-year-old male who presents to the ED with his spouse for a 3-month history of lethargy. He notes that for the past few months, he has been tired to the point where he cannot complete activities of daily living, ADLs. The patient describes a 1-week history of right lower quadrant pain, as well as intermittent nausea, vomiting, and diarrhea. That's what N/V/D stands for. For the past 2 weeks, he has noted that when he wakes up at night, he has unsteadiness on his feet, of which he doesn't notice during the day. He describes shortness of breath, weakness, headache, and dizziness, but he denies fevers, myalgias. Myalgias just means body aches, chest pain, or loss of consciousness. Of note, the patient recently immigrated from Scandinavia, specifically Denmark, where he often indulged in dishes that contain raw fish. No significant past medical history, and no home treatments for this episode of symptoms. Okay, so questions that we want to consider. What other things should we ask our patient? What ideas do you guys have? What other things do you want to know? Good. Good, Maddie. So Maddie says we should ask about bowel movements and appetite. Could have a fish tapeworm that caused his anemia. Medications, great. Ashley, perfect. Maddie, why do you want to ask about appetite specifically? Allergies, good. Pain in the abdomen, yeah, we want to find out what kind of his abdominal pain sort of consists of. I know that Karan taught you guys about abdominal pain and did a really good job last week. So you guys probably are experts at that by now. What else? If anything alleviated the pain, good. Yeah, perfect. Anything else we want to ask him? Meds, good. We certainly want to ask about his medications. Anything else? So what details about his history are of the utmost importance? I did bold a few things, but you guys let me know. What do you think are important, or what is kind of sticking in your head? The location of the abdominal pain, certainly. So that location of the abdominal pain, what do we want to consider? And what other things are important to you guys? He ate raw fish, exactly. Good, perfect. Anything else that was important to you guys? Lethargy, good. Makes sense for anemia if red blood cells are carrying less oxygen, absolutely. He's lethargic and weak. So somebody thinks there's a B12 deficiency out there, possible appendicitis, good. History of lethargy. You guys are all right, and you're picking up on very pertinent symptoms that we want to kind of hone in on in order to make sure that we're getting closer to the diagnosis of what this patient may have. And what details are significant about his history specifically? Other than the fact that he ate raw fish, what else is kind of significant? And then which body areas do you want to examine on this guy? Stomach, good. Yeah, we want to take a look at his abdominal pain. Absolutely. What else? Somebody mentioned that he might have an anemia. What do we want to look at if we're considering that somebody might have anemia? What physical exam findings might we have? SpO2, good, yeah. Conjunctiva, good, perfect. Hopefully you guys remember that from the GI lesson. Does anybody remember, if you were here with us for the first session about GI bleeding? What do we want to look at to see if he might be anemic? Good, palms, what else? Anybody else have any other ideas what we want to examine? CBC. We certainly do want to look at a CBC. Stool, yeah, You guys are all on the right. Scleral icterus. So close, Maddie, you're close. We're looking for conjunctival pallor. So you're right on track with that. And basically what we're looking at is the anterior rim. So for me, you see it's nice and pink. For this person, it may not be if they are anemic. Exactly. So the inside of the eyes for whitish color, which would indicate that this person might be anemic. You guys are absolutely right. Good job. And as you can see here, I've added a photo for you there. And that is indicating just that. So before we get to that, let's talk about our vital signs. So this patient has a temperature of 99.3, has a heart rate of 103, has a blood pressure of 101, 101/67, and a respiratory rate of 24. So he's tired appearing, but he appears a stated age. His pupils are equal, round, and reactive to light and accommodation. That's what the PERLA means. He's normal cephalic, atraumatic. Mucous membranes are dry, and there's evident pallor to the anterior rim of the eye. And that's exactly what this is kind of showing here. Other than that, he's tachycardic. His heart exam was tachycardic with a 2 out of 6 diastolic heart murmur. And this is heard best at the left sternal border. His pulses are good. His radial and dorsalis pedis pulses are good. His lungs are clear to auscultation, and he has diffuse abdominal tenderness. And he had a negative McBurney's point and negative Rovsing sign. Do you guys remember what McBurney's point and what Rovsing sign are testing for? I know that Karan, yeah, good. He taught you about that last week. What about Rovsing's? Yeah, so Rovsing's is also for appendix. It can be for an abscess, so you're absolutely right, Tuba. You're on the right track. It can also be due to inflammation of the appendix in general. And what we kind of see there is when you push in the left lower quadrant, it hurts the patient in the right lower quadrant. That's what Rovsing's sign is. McBurney's point is the point that's 2/3 the distance from the anterior superior iliac spine to the umbilicus. So 2/3 the distance, that's McBurney's point. That tells us there might be inflammation at the appendix there. Okay, so to redirect your attention back to this, this pallor in this gentleman's eyes, do you guys notice anything different or anything other that is abnormal for this photo? I was looking back through my slides and I noticed this, and I want to see if anyone else can pick up on this. I will be very impressed with you. He does look a little bit jaundiced. You're probably right. What else? I'm looking at his eyes. Yeah, good. Do you know what that ring on his eye is? So it isn't a Kaiser-Fleischer ring. You're close. So copper ring looks a little bit different. Similar to a cataract, a little bit different though. Cholesterol, perfect. You're absolutely right. So somebody had indicated that it's cholesterol, and you're absolutely right about that. So good job, I'm very impressed. What we call this is corneal arcus. And so what you can see is, let me pull out my pointer here, is this right here. So if you look at his eyes, if you're not paying attention, it may just look like he has blue eyes, which isn't actually the case if you look here. So his eyes are actually brown, and he has this ring around his eyes, which is a sign of hyperlipidemia, increased cholesterol kind of deposited on the top and the bottom of the iris. So then you get kind of this ring of cholesterol around. We call that corneal arcus. So let me write that up here for you so you can see it. So that's what we call it. We call it corneal arcus. And this really isn't related to anemia by any means, but just so you guys kind of have that on your radar in the future. Okay, so let me clear all this. All right, and let me go on to the next slide here. So here's our labs. So let's start kind of the left and go towards the right here. So we see our CMP here. I put a key over to the left here for you. So it looks like our CMP is normal. Our sodium is normal. Our potassium is normal. Everything is normal, including his glucose. Though we see a different story when we look at the CBC. So first, we see that his white blood cell count here is elevated. We want that kind of around 5 to 11. And then we also see that his hemoglobin is low. If you remember the rule that I taught you last time in the GI, the hemoglobin times 3 equals our hematocrit, which is this number down here. As you can see, it's exactly spot on. The hemoglobin here times 3 is the hematocrit. That's how you can kind of tell the accuracy of the lab value usually. Other than that, his platelet count is normal. So when we see a hemoglobin that's low and a hematocrit that's low, what parameter in the CBC do we also want to look at? Red blood cell, perfect. What else? So we do want to look at the red blood cell count. You're absolutely right, Holly. Anything else? MCV, good. Why do we want to look at the MCV? Macro versus microcytic, good. I feel like you guys know a lot about anemia. You were all bluffing. Or you all drink your coffee, as we sort of talked about before. But as we can kind of see here, a normal MCV is around 80, that's a terrible 8, 80 to 100. So 80 to 100 is a normal MCV, and as we can see, this MCV is elevated. So we have macrocytic cells. It means that our cells are large, our red blood cells are large. Also of note, we have a decreased serum B12, and we have an increased methylmalonic acid. That's what MMA stands for. And then as we can see here, our iron value is normal. So what does that rule out? If our iron is normal, what does it rule out? Don't overthink this one. It's easier than you think. Iron deficiency anemia. Good job, Zena. Perfect. So it rules out iron deficiency anemia. So if our red blood cells don't have enough iron to incorporate into the hemoglobin, we can get an anemia as a result. Our iron here is normal, which means that we don't have to look into other iron studies to kind of get to the iron deficiency anemia. Other than that, we did a differential on the white blood cells. So basically what the white blood cell differential is taking the white blood cells and kind of classifying them under different classifications based on the cell type. I did that for a few years. I worked in the lab at Johns Hopkins for many years. I was the person in the lab telling you your differential. And I enjoyed doing that a lot. And I saw quite a few leukemias when I worked at Hopkins, but that's neither here nor there. Here, we can kind of see that the eosinophil count is very, very elevated. Can anybody tell me what eosinophils are for? Inflammation. So what white blood cells are for inflammation, allergies, and parasite. Absolutely right. So the way we kind of look at it is twofold. So classically, eosinophils are for parasites, though due to the fact that kind of in our world, meaning in the United States, in developed countries, we don't really see a lot of parasitic infections. They've kind of sort of migrated to be more allergic in nature. So all of you guys that answered either parasite or allergies, you're absolutely right. Both of those things are correct. So let me clear all this and let us kind of move on and see what else we have here. So I always ask you guys, I want you to annotate for me, is this a normal peripheral blood smear or is this an abnormal peripheral blood smear? So take a look at a few things. Take a look at the red blood cells themselves. We see a segmented neutrophil there, and we see a lymphocyte there. But mark using the annotate. Mark for me. Is this normal or abnormal? Okay, so those of you that had indicated that is abnormal, tell me why. Why do you think it is? Why do you think it is abnormal? Why is this not a normal peripheral blood smear? So somebody wrote, somebody wrote in the abnormal, the neutrophil has lots of segments. So you're absolutely right. So what might that indicate to us? So somebody mentioned that the neutrophil, the PMN, they're called PMNs because they're polymorphonuclear cells. As you're probably learning in medicine, we have to call everything by 100 different names or else it wouldn't be medicine. But what we're looking at is this guy right here. So we're looking at this neutrophil. And as you can see, he kind of has 1, 2, 3, 4, 5, 6, 7, 8, maybe 9, a lot of what it looks like segments in there. So it's kind of hard to discern, how many lobes it has because we can't really move around or focus the microscope here, but there is certainly a lot of segments here. And the hypersegmented neutrophil, absolutely right. It might indicate either a B12 deficiency or what else? A hypersegmented neutrophil can also indicate another deficiency. Exactly. Folate deficiency. You guys are both correct. Good. What do you guys notice about these red blood cells as well? Are they normal? Are they small? Are they large? What do you guys think? They look to be too large. Exactly. So what can we kind of use as a ruler when we look at the peripheral blood smear in order to indicate if these are large or not? Good. Nucleus of the lymphocyte. I feel like Parab, I feel like you are in hematology course right now, or you work in the lab yourself. You know a lot of this, and I'm impressed. So, and that's absolutely right. So, whenever I look underneath the microscope, I look at either two things. I look at the white blood cells, so you can look at a neutrophil, but I like to look at the lymphocyte. That's the best way to do it. And what's going to be important here is to look at this lymphocyte. And as we can see, this lymphocyte's next door neighbor is huge. This red blood cell is larger than the lymphocyte nucleus and of the lymphocyte itself. So it's small. We have what might be a schistocyte, a fragment cell here. And this cell really that I circled here is probably a reticulocyte, an immature red blood cell. So that might indicate to us that the bone marrow is a little bit panicked and shooting out cells in order to kind of compensate for the anemia. Okay. So let me clear all this. You guys are absolutely right, and you guys are on track here. You guys are doing great. So somebody said that they wanted to get a stool. Here you go. Whoever told me that you wanted to get a stool, what is this? What are we looking at? Is this normal or abnormal? Good. So we are looking at an egg. Bonus points for anybody that can get this. So basically what we're looking for in the stool is an ova and parasite. That's kind of the test that we order when we mark it on the requisition form. We're calling it an ova and parasite. And what this arrow is kind of denoting here is this egg here, and what we call this is it's operculated. And so as you can kind of see here with these dots, it kind of has this knob on it, and this is very characteristic of one specific parasite. So whenever we had talked about in the history one specific thing, so this specific egg, what does it line up with in his history? Is there something that's kind of flat, clicking here? You have a light bulb moment from fish. Good, exactly. That's exactly right. So he ate raw fish. Perhaps this is from that. So let's see what else. Fish parasite. You guys are right, but there are a few fish parasites. And here you go. Here's your atlas of human parasitology. So there are a few that kind of come from fish. The one that we kind of want to be cognizant of is you guys are going to find out which one kind of looks familiar to you on this atlas of parasitology. Are any standing out? Do you see an operculated egg anywhere? Is marked E. vermicularis. Somebody marked Diphyllobothrium. Good. Good. So keep your suspicions high. We will kind of we'll kind of move on. My favorite for note, my favorite parasite is Trichuris trichuria, just because it has these like cute little knobs. I don't know. I just think it's so easy to identify, but I mean it's not cute for the patient though at all. It's a not any parasite infection is not great. But so let's keep it moving here. So our differential diagnosis. I think at this point we can be fairly certain that this patient has an anemia. And what do we call this again? What kind of anemia are we calling it? I wrote megaloblastic. What's another word for this? Pernicious. You're close, Holly. You're close. Pernicious is kind of referring to when there is something of which is basically attacking the parietal cells or intrinsic factor, which is causing a malabsorption of vitamin B12. That's called a pernicious anemia. We kind of look for that antibody of which is attacking itself. Anybody else? Think back to the MCV. What did the MCV tell us? Macrocytic. Perfect, Zena. You're absolutely right. This is a macrocytic anemia. And we know from the labs also that we're looking at a B12 deficiency. The rationale behind the B12 deficiency, remember the raw fish? So that is absolutely what we're looking at here. Perhaps the raw fish contributed to this. We're looking at a Diphyllobothrium latum infection. And that's what the egg that we saw before, which was this one. So those of you that pointed that out or had that suspicion in your head, It's this one. It has that operculated, it's pretty large and has that operculated knob, and is contributing to the patient having this vitamin B12 deficiency, due to the fact that the parasite is not only there, but sort of inhibiting or preventing the absorption due to its effects in the intestines. So obviously we see that the anemia is likely due to the labs and the stool results. But as Holly kind of mentioned as well, can we completely rule out a pernicious anemia? No, not necessarily at this point. So it could be a pernicious anemia where we have kind of an antibody of which is contributing to malabsorption of B12 and the intrinsic factor complex. So that's what IF stands for here. Or we could have a dietary deficiency. That's probably less likely. It's why it's lower on our differential. Folate deficiency, this is probably just for completeness sake of having a complete differential. Do you guys know why the folate deficiency is less likely? Do you remember what lab? Good, yeah. Parab is on top of it today. He drank his coffee, or she. So the folate deficiency is less likely because we had an elevated MMA, which is methylmalonic acid. That's kind of how we're going to differentiate folate from B12 deficiency. In both folate deficiency and B12 deficiency, we're going to see an increase in homocysteine. The way we differentiate B12 deficiency is the methylmalonic acid. The methylmalonic acid will be high in or methylmalonic acid will be high in B12 deficiency. Perfect, good job, Tuba as well. So, and then the last thing on our differential that we could include is a defective DNA repair, which is also called Fanconi's anemia. It's very less likely, no physical exam findings indicative of this. So that's also kind of just on there for completeness sake. Fanconi anemia, the same thing as Fanconi syndrome, yes. Anemia is kind of the a factor in the syndrome. So the syndrome is where we see kind of the deformities in the thumbs as well, and defective DNA repair. Okay, so let's clear that. So our assessment and plan. So what do we want to do for this person? Think about their hemoglobin and hematocrit. Think about what this patient is presenting with. What do we want to do for this person? We know that they have a parasite. We know that Diphyllobothrium latum is, inside of this guy, sort of evident by his stool cultures. And we know that he has an anemia. So what do we want to do? Do we want to send him home and say, drink lots of fluids? Antiparasitic drugs, good. Transfuse, yeah, good job, Tuba. I was looking for both of those answers. So you and Holly and Ritu, you guys are both correct. All three of you are correct. So we do want to give an antiparasitic drug. We also want to transfuse red blood cells. If we had to pick which one should come first, which do you think is a higher priority at this point? Good, transfusion. I agree with you. A few of you guys said the antiparasitic. I think transfusion certainly comes first, but in a situation like this, we may not have to prioritize one over the other. We want to think about our ABCs, airway, breathing, and circulation. The blood kind of comes into consideration with the circulation. Do we need to provide B12, or will that restore after the parasite is treated? Great question. So I was reading a little bit about this, this weekend, and there's studies that show a lot of the time the B12 level will kind of will kind of go back to normal after he is treated. But due to the fact that his B12 levels kind of in the deficient range, we can certainly supplement him. That won't hurt him at this point. And he is symptomatic. Do you guys remember a physical exam finding from a few slides ago? Do you remember the cardiac exam? What was there a specific finding that stuck out to you about the cardiac exam? Tachycardia, good. So Tuba said diastolic, good. Yeah, you guys were, there's a heart murmur. So this is a heart murmur. It's usually a diastolic murmur. It's an innocent heart murmur, kind of due to the increased flow through the heart arteries. And so basically what happens is there's a lot of turbulence, which is causing this diastolic heart murmur. Usually this is an innocent murmur. And the other kind of cardiac effect of anemia is high output cardiac heart failure. So we can kind of see that as a result as well. So anemia, even if they're asymptomatic, can lead to consequences if it's not sort of treated. So you guys are all right. All of that to say, you guys are absolutely right. We want to transfuse 2 units of RBC, so we want to trend the H&H. We also want to give praziquantel for the Diphyllobothrium latum infection. And then somebody else sort of mentioned it as well, but in terms of the antiparasitic, and any drug that we give, we always want to kind of watch for side effects and adverse reactions. So this is your small lesson in pharmacology. So here we want to look out for hypersensitivity reactions. We want to look out for arrhythmias such as AV block. We want to look for bradycardia or atrial fibrillation. And also we want to look for seizures or polycerositis or even bloody diarrhea. Those were the kind of big ones that we should look out for. Other than this, we want to begin B12 supplementation. So due to the fact that he's deficient, it's never a bad idea to kind of supplement that as well. So good job, you guys. You guys were all on point with that. And so here's a table. It looks overwhelming, but let's kind of break it up. Let's go through it. So we're going to spend a considerable amount of time on this chart here. So as we can kind of see here, let's start obviously up here at the chart at the beginning. So when we talk about anemias, what we're going to do is look at the MCV. And as you can kind of see, each of these categories of anemias are really kind of broken up into what MCV we're looking at. And do you guys remember what MCV were we looking at this evening with this gentleman that we had with this infection? Was it microcytic, normocytic, or macrocytic? Good, it was macrocytic. You're absolutely right. We were looking at an MCV of 111. When I made this case, I made it very obvious to you guys that this is a macrocytic anemia. So good. And then when it's in a normal range, 80 to 100, it's a normocytic anemia. The way that I always remember MCV for anemias is if I got an 80 to 100 on an exam, that's normal to me. I can do that. That's fine. That's great. So that's, I don't know, it's a weird thing that I always remember. Then the other thing is really the important thing to remember is what's normocytic. If you remember one thing, you remember the others. So normal is 80 to 100. If it's greater than that, it's macrocytic. If it's below that, it's microcytic. So that's just kind of the easier way to look at it instead of remembering all these different things. So study smarter, not harder. So let's start over here with microcytic. So when the MCV is little, we're looking at sort of little cells. So here's my little red blood cell. Or let me make it actually a red blood cell. So here's my little red blood cell. So what we're looking at here is thalassemias. So there's something called a beta thalassemia, so a problem with the beta genes, or an alpha thalassemia. That was a horrible alpha symbol. And then also we look at anemia of chronic disease. The problem with that is anemia of chronic disease can be both a normocytic anemia or a microcytic anemia. Usually the more severe, the more microcytic it becomes. So keep that in mind. We talked about iron deficiency anemia. In the same way, late iron deficiency, the more severe it becomes, the more microcytic it becomes as well. Then lead poisoning, remember this one as well. We don't see a lot of lead poisoning really now, and it is screened in pediatric offices. I just finished my pediatric rotation, and that was something that they certainly did, was lead screenings and sort of asking, you know, if children might be exposed to lead. And it's usually like houses built less than 1948. So that's like a fact to remember. Whenever you guys get to your board exams, you can keep that in your head. Other than this, when we kind of look, other than this, in terms of the MCV, when it's in a normal range, 80 to 100 femtoliters, that's what the FL means. This is a normocytic anemia, so it means that our cells are kind of normal. So there's my normal red blood cell. So we kind of talked about a few of these. Aplastic anemias here, as well as anemia of chronic disease and iron deficiency. We talked about those. Chronic kidney disease is a normal normocytic anemia. And these are non-hemolytic anemias, meaning there's no hemolysis or bursting of the red blood cell. Of note, this is a low reticulocyte index. I showed you a reticulocyte before. It means that the bone marrow is not producing these immature cells to kind of compensate. On the other hand, hemolytic are usually have a high reticulocyte index, so they're producing those retics. And then we can have intrinsic causes of hemolysis or extrinsic causes. Intrinsic meaning a problem inside of the system essentially, and extrinsic meaning sort of something external to it. In sort of the intrinsic, we like to think of hereditary spherocytosis. It's a problem with the membrane. PNH, which is a problem also with the membrane as well. And then G6PD deficiency, where you have a problem with an enzyme that causes the cell to hemolyze. Same thing with pyruvate kinase deficiency. And then there's also kind of the famous sickle cell anemia as well. And then there's these other causes here. These are kind of less important for our discussion today. But, and then the other thing that we kind of are going to talk about is macrocytic anemia. So that's certainly what we're talking about today. So here's our giant red blood cell to kind of get the picture. And the two ways that we're going to talk about it, first we'll talk about non-megaloblastic, meaning it's not a problem with the DNA. And we talk about Diamond-Blackfan anemia. And also liver disease and alcoholism, which, you know, sometimes these two things go hand in hand. The other one is megaloblastic, which is certainly what we're talking about today. We're talking about a B12 deficiency. We also see folate deficiency is right under the same category. So, just to kind of provoke your memory here, how do we differentiate folate deficiency and B12 deficiency? Good, Holly, perfect. Yeah, right on point. MMA, that's exactly right, which is methylmalonic acid. So when we don't have vitamin B12 as a cofactor, we get a buildup of methylmalonic acid. So I'm going to show you a diagram here in a few slides that indicates that. And then here's a defective DNA repair. We put this on our differential diagnosis, which is Fanconi anemia. Okay, so hopefully this makes a little more sense to you guys. You're going to see this chart a few more times. I'm going to ask you a few questions in the poll, and you're going to be able to really pull this out of your memory, hopefully. Okay. All right. So our etiology and risk factors for anemia. So this is kind of broad in terms of anemias in general. But when we think about anemia, we want to consider the diet. Are they taking up enough vitamins that they need in order to produce healthy red blood cells? So as you guys have kind of learned, what are kind of 3 or more vitamins that we want to kind of consider in somebody's diet that can lead to a anemia? B12, good. We learned that one today, perfect. Maddie? Folate, iron, and B12. Holly hit the perfect trio. That's exactly what I was looking for. Great job. So folate, iron, and B12, those are certainly things that we want to consider. What kind of diets are low in either folate or B12? They'd love to give you this on test. Vegetarian, vegan, perfect. Yeah, that's exactly right. They love to give you somebody of whom is very sort of adherent to a vegan diet, and they sort of correspondingly are very tired, lethargic, they have the anterior rim, all of these things, okay? Other than this, we want to consider other things like Crohn's disease that affects the terminal ileum, where vitamin B12 is absorbed. And then we want to talk about celiac disease as well, where you get sort of malabsorption disorders as well. The other thing is previous GI surgeries. If you had bariatric surgeries, you had a colectomy, different things can lead to short gut syndrome and malabsorption. For the ladies, we want to consider menstruation. We do lose a little bit of iron in menstruation, and so that's something we want to keep an eye out. If you see someone of whom is having very heavy periods, besides thinking about von Willebrand's disease, we also want to consider, are they anemic? And if they are, the most likely cause perhaps is iron deficiency. Other things is pregnancy, because your demand for these metabolites goes up because you're not just you know, sort of having nutrients for yourself, but also a different kind of parasite growing inside of you, a baby. And the other thing is chronic conditions. So we want to consider anemia of chronic disease. So different things like rheumatoid arthritis, cancers, different chronic conditions can lead to anemia of chronic disease, which, as we remember, is a normocytic anemia early and a microcytic anemia late. Other things that we want to consider: genetics and autoimmune. We want to consider sickle cell anemia. They love to give you those little sickled cells. G6PD deficiency, hereditary spherocytosis, and thalassemia, where there may be a problem with alpha or beta chains in the hemoglobin. Okay. So here's that diagram that I was alluding to before. So as we can see, vitamin B12 is essential to this pathway. I don't love pathways. I think a lot of them are hard, and you guys are probably taking biochemistry, and hopefully you guys are doing well and you're staying afloat in it. But vitamin B12, as you can see here, is essential to this pathway. It's a cofactor for folate to be tetrahydrofolate using the enzyme methionine synthase. Similarly, homocysteine is produced to methionine, of which is in turn used for methylation reactions. As we can see, if vitamin B12 is not here, we also get a buildup of these precursors, of which is methylmalonic acid. So hopefully that kind of makes a little more sense, and you understand it as opposed to just memorizing that. And then similarly, if we get a problem with vitamin B12, we get a problem with DNA synthesis, DNA methylation reactions. And so we get these hypersegmented neutrophils. And what we're looking for really is greater than 6 lobes on this neutrophil. So we see like 1, 2, 3, 4, 5, maybe 6, 7. So these are certainly hypersegmented neutrophils. So those are the 2 things we're really looking for here. So, all right. So for the physical exam, if you can remember, he did mention that he was a little bit unsteady on his feet. You know, this is no kind of coincidence. This is certainly kind of lines up with something we consider with a B12 deficiency, and that is called severe or subacute combined degeneration of the cord. It's called SCD. And what happens is when there's low B12, we correspondingly get demyelination of the posterior columns. So the posterior columns, here's a cross section of the spinal cord. What we're looking at is these right here. So here and here. And when we don't have that B12, they get demyelinated. And what the posterior columns is used for is proprioception, which is kind of feeling where you're at in space. So if you remember, he was unsteady on his feet when he couldn't see, which meant that he had an altered sense of proprioception. Also, if we tested his vibratory sense, if we got the tuning fork and placed it on his toe, he may not be able to feel that vibratory sense. Other than this, we might see kind of a tachycardia, hypotension due to the decreased blood volume, also called hypovolemia. And then we can see a high output cardiac or high output heart failure. And then we can also see a diastolic murmur. Other than this, we can see abdominal pain and tenderness, and we can see pallor as well. So we kind of judge that by the anterior rim, and we can see it by cap refill, not necessarily the anemia itself, but their relative state of hypovolemia. Okay, let me clear that. All right, so complications that we kind of want to consider. We talked about a few of these, and you can get extensive lethargy or fatigue. That's really what we kind of think of when we think of anemia. For folate deficiency, we want to think about women of childbearing age. If they have a folate deficiency and they become pregnant, this can lead to neural tube defects. That's why women of whom are in their childbearing age are often recommended to take prenatal vitamins, to take vitamins of which have folate in them, due to the chance that they become pregnant in the first trimester. There's no neural tube defects, of which will lead to problems with the fetus. Other than that, heart failure, arrhythmias, neurologic, we can see altered mental status, and we can see that severe combined degeneration of the cord, which we talked about in the last slide. Also, we can see increased risk of infections and anemia of chronic disease. We can also see death as well. Okay, so now to the questions. So in the bottom left-hand corner, there's the slide for you of which shows that chart that we talked about. So for this question, I just started sharing it whenever you're ready, but this is a 3-year-old boy who presents to the ED with confusion, headache, nausea, and vomiting. The mother states that they live in a house built in 1938. Remember my foreshadowing from before about 1948. She has caught the boy eating paint chips from the wall. So is this a micronormocytic or macrocytic anemia? I'll give you guys a few more seconds here. You guys are doing great. All right, I'll end it there. So the vast majority of you guys, good job. You said a microcytic anemia. So perfect. So what are we looking at here? He's eating paint chips off the wall, and they're living in an old house built in 1938. So what are we concerned about here? Good, lead poisoning, absolutely right. The things that we look for in lead poisoning, we can kind of see it depositing on the gum line. We can see problems with confusion, altered mental status. We can see the lead lines in the bones as well. And this is a problem for children because they're still sort of developing neurologically. And as you kind of remember from the chart, lead poisoning is a microcytic anemia. So we would expect to see an MCV less than 80. All right. So here's our next one. Let me relaunch this for you. So this is a 17-year-old female. She's presenting with fatigue and pallor. She notes that she adheres to a strict vegan diet. So what are we looking at here, guys? Are we looking at a microcytic, a normocytic, or a macrocytic anemia? I'll give you about 15 more seconds so we can reach all of the questions. If you guys get 100 on this, everybody answers macrocytic, I'll be very proud. All right. As I kind of alluded to, this is certainly a macrocytic anemia. What's her risk factor here, guys? Good. She adheres to a vegan diet. In what kind of nutritional deficiency are we looking at here? Specifically, probably two of them. Yeah, B12 and what else? Or folate. Good, Maddie. Yeah. Vitamin B12 or folate, exactly. And as we kind of know, this inhibits having vitamin B12 or folate not available leads to decreased DNA synthesis. So we have a problem sort of synthesizing DNA, and that's why we get these hypersegmented neutrophils. You guys did very well on this. Okay. Let me relaunch this and we will go on to the next one. So this is a 55-year-old chronic alcoholic presenting with abdominal pain and fatigue. He drinks a 6-pack per day and he was diagnosed with cirrhosis in the past. Also use in addition to the ascites shown for you, use the kind of the peripheral blood smear to kind of lead you on this one. I picked a very particular peripheral blood smear for you guys. Let's see if you guys can't get 100%. All right. So the majority of you guys did very well. 71% of you said macrocytic. What made you say macrocytic other than the peripheral blood smear? What clues kind of tell us that this may be a macrocytic anemia? Liver, good. Yeah, liver disease, cirrhosis, exactly. That can kind of lead to a non-megaloblastic macrocytic anemia. Good, perfect. And if you look at this peripheral blood smear, we see pretty large cells here. We see normal sized cells in here. From this this sort of peripheral blood smear itself, what we can see really is this is maybe kind of a normal cell here. But as we can see, this cell is huge. This is a macrocytic anemia. This one is almost like a perfect red blood cell, really. And then its neighbor here is ginormous. Probably it's a little bit purple. It might be an immature red blood cell, a reticulocyte right after it's kind of extruded its nucleus. So its nucleus would usually be in here, kind of a purple color, and then it extrudes it. So the size of it would lead me to believe it might have extruded its nucleus fairly recently, but before this this slide. But okay, so I think we have one or two more. So let me relaunch it and go on to the next slide for you. Clear all this. All right, so this is a 4-year-old male. He's presenting with his mother for acute shortness of breath and chest pain after traveling to Denver for vacation. He has a past medical history significant for sickle cell anemia. You guys are doing great. I'll give you guys a few more seconds. Those of you that haven't voted, I'll let you have a couple seconds to throw in your vote. All right. So you guys did very well. This is a normocytic anemia. We're looking at sickle cell disease. So we're looking at an intrinsic problem with the red blood cell itself. And we see basically a MCV that's normal with this. Don't let the kind of sickled cells sort of deter you away from thinking this isn't a normocytic anemia. I know that seeing those sickled cells, you're like, well, isn't this a microcytic anemia? So I understand where you guys are coming from, those of you who said microcytic. By definition, the MCV, the mean corpuscular volume of the cell, that is considered in a normal range for sickle cell anemia. Given in this small vignette, what might have kind of triggered this sickle cell crisis? Good, yeah, low oxygen tension in the blood and altitude change. Both of you are absolutely correct. A lot of times the altitude changes causes a problem with the dissociation of oxygen, which causes low oxygen tension and a corresponding sickling of those cells. Does anybody know what is the treatment of sickle cell anemia? Hydroxyurea, exactly. Purab is absolutely right. And transfusions, yeah, absolutely right as well. If they end up getting a low hemoglobin, you can absolutely transfuse them. What do we look for when patients are getting chronic transfusions? What do we have to be meticulous about? Hemochromatosis is close. It's similar to that. It's just another word for it, basically. Hemochromatosis is a genetic deficiency with iron. We're looking at something very similar. Iron overload. Good job, Tuba. Absolutely right. When we're transfusing a bag of packed red blood cells, we're also giving them iron. So we have to be careful that we're not iron overloading them. So that's absolutely right. And then to jump back to the hydroxyurea being the treatment for sickle cell anemia, how does hydroxyurea treat sickle cell anemia? What does it do for it? Good. It increases the fraction of fetal hemoglobin, which has a higher affinity for oxygen. So good job. Both of you are absolutely correct. Good. So I'm going to stop sharing these results. I think that was our last one. Oh, we have one more. Let me relaunch this. So this is a 44-year-old female. She's a past medical history significant for lupus. She presents with fatigue and confusion. So let's just say for, based on the peripheral blood smear and based on her history, that she's had lupus for many years, since she was 20. I don't know if that changes your guys' answers any. So about half of you are in, so I'll give you a little bit of time. Okay. So let me share these results with you. You guys are almost split between normocytic and microcytic. Someone from each, either microcytic or normocytic, tell me, why did you choose normocytic? Somebody of whom chose normocytic. Why did you choose normocytic anemia? Autoimmune. Okay, normocytic autoimmune, good. Yeah, it could certainly be autoimmune in the way of, you know, because it's an autoimmune condition. When we look at autoimmune conditions over here for extrinsic, we're looking a little more at autoimmune hemolytic anemia. Microcytic because of late stage autoimmune. Exactly. What we're looking at really is an anemia of chronic disease, which you guys are right, normocytic for a different reason, but you guys are right, because anemia of chronic disease can be both a normocytic anemia and a microcytic anemia. When it's kind of been there for a while, it's usually microcytic, late stage, and then normocytic otherwise. The autoimmune part that's listed in the chart, that's a little more autoimmune hemolytic anemia, either warm autoimmune hemolytic anemia or cold autoimmune hemolytic anemia, where cold autoimmune hemolytic anemia is a problem with IgM. Warm is a problem with IgG, okay? So you guys are split down the middle, so I would like to think the majority of you all got this question correct regardless, so you're both right with that. Alrighty, so I think that was the last one. Yeah, I was. So let me close that. All right, so we're gonna go on. This is a G6PD cartoon. I always like to include these med comics. So this is an X-linked recessive disorder, and really it's a problem with the G6PD enzyme, and when they're exposed to certain metabolites, they're not able to sort of have this reduction reaction in order to deal with these insults, whether it's sulfonamides like TMP-SMX, nitrofurantoin, dapsone, primaquine, quinidine. Primaquine and quinidine are used for malaria. So really they're not able to have a functional enzyme of which can handle the oxidative stress, okay? So, and that was just kind of a side lesson for this. Obviously, today we talked a lot about megaloblastic anemia and a little bit about the other ones. So this is my last slide. So really, in order to diagnose anemia, what we're looking for is the labs. We're looking at the CBC, we're looking at the hemoglobin and hematocrit, and as you learned, the way that we really classify these anemias is by the MCV, the mean corpuscular volume. Other than that, we're going to look at folate and B12 levels kind of as a follow-up. If we know that the MCV is high, then we're going to look for folate and B12 levels. What kind of MCV would we kind of be looking for iron deficiency anemia? Micro, good. And there was a question, please repeat early and late stage anemia of chronic disease. So for early anemia of chronic disease, usually that's a normocytic anemia. Late stage anemia of chronic disease, that's usually a microcytic anemia, okay? And for iron, yes, we're looking for a microcytic anemia. And then for enzymes, if we know that this is a normocytic anemia, so we can write an N here for normocytic, we would look at G6PD, we would look at pyruvate kinase, those two enzymes which kind of contribute to a normocytic anemia. Other than that, we would look at genetics. We could do a hemoglobin and electrophoresis to look for beta thalassemia or I couldn't redeem myself and draw a better alpha symbol. Alpha thalassemia or hemoglobin C disease. Those can all sort of also contribute to an anemia. Other than this, for the treatment, what we want to do is really pinpoint the underlying cause. While we can transfuse these people, does anybody remember what the cutoff is for transfusion? If we say if the hemoglobin is less than this value, we want to consider transfusion. We have an 8. Does anybody else have another answer? If the hemoglobin is just less than 7, we want to transfuse. 8 is a significant number for their GCS score. If their GCS score is less than 8, then you want to intubate. It kind of rhymes, so it's easy to remember. But usually if the hemoglobin, and there might be different parameters based on your institution. So 8 could be correct where you are too, but you may be absolutely right. What I've learned is 7. So for these anemias, we want to treat the underlying cause. If there's an iron deficiency anemia, microcytic anemia, we want to replace their iron, give them iron. If they have a vitamin B12 deficiency, depends on the cause, certainly. We want to give them B12. If they have a diphyllobothrium latum infection, we want to give them praziquantel. If they have a folate deficiency, give them folate. If they have a sickle cell anemia, then we might want to consider hydroxyurea. G6PD deficiency, then we want to avoid triggers. MMA stands for methylmalonic acid. That was the metabolite that we talked about when B12, the cofactor for that reaction, will start to build up because we don't have the B12 to kind of fuel the reaction. Okay. So let's see here. I have one more question for you guys, and that is your post-poll. So take a couple seconds here to answer my last question for you. I'll give you guys a couple more seconds. This might be your easiest question, hopefully. All right, great. So a lot of you guys said that you know a fair amount. I appreciate that. 74% of you said that you know a fair amount now. And a few of you, we had nobody said that they know a lot, and 6 of you, 22% of you said that you know a lot now. It's very humbling. I appreciate that. I hope that you guys did learn a lot. I certainly enjoyed my time with you for the past hour or so. If you guys have any questions at all, feel free to stay on the line, ask me any questions, or you can type them in the chat, but I'll wait around a little bit. As always, we'll be back next week on Wednesday in order to have another session. My colleague Emma will be presenting on a topic in emergency medicine. If you guys have any questions, please let me know. Otherwise, we'll see you guys next week.